Okay, I go to talking about enzalutamine in men with non-metastatic castration-resistant prostate cancer. Definition: men with non-metastatic castration-resistant prostate cancer and rapidly rising prostate-specific antigen (PSA) level are at high risk for metastasis. We hypothesize the enzalutamide, which prolongs overall survival among patients with metastatic castration-resistant prostate cancer, would delay metastasis in the men with non-metastatic castration-resistant prostate cancer and rapidly raise PSA level. This is a video.
Enzalutamide is also being studied intently in M0CRPC. And the trial that is recently completed is called the PROSPER trial. And that's a large phase 3 randomized trial looking at men with this non-metastatic castrate-resistant prostate cancer, randomizing those men 2-to-1 to the oral anti-androgen enzalutamide versus placebo. We don't know the official results of the trial, but in mid-September of 2017, Pfizer, which now owns the rights to the drug, reported a press release saying that enzalutamide met the criteria for success and they would be submitting an application to the FDA for expansion of the label. Remember, enzalutamide has been FDA approved for a number of years to treat metastatic castrate-resistant prostate cancer, but the current label does not include M0CRPC. What I don't know is this: will the FDA act more quickly on this request for label expansion and open the doors to using it in M0 prostate cancer fairly soon? Again, as of late 2017, as we're talking now, enzalutamide is not yet FDA approved for M0CRPC.
Enzalutamide is a FDA-approved orally available therapy that has been approved in two contexts in metastatic castration-resistant prostate cancer. One is in patients with metastatic disease that has progressed after docetaxel chemotherapy, and in the other setting, it's approved in patients who have asymptomatic or minimally symptomatic metastatic castration-resistant disease. In studies in both of those contexts, enzalutamide demonstrated a significant improvement in progression-free survival compared to a placebo. It also demonstrated a significant improvement compared to placebo in overall survival. It's a well-tolerated, orally available therapy. Many patients are able to take it without significant problems for months or even years. As we've been able to give more and more of it, there have been a few toxicities that have emerged that are of concern. One is some cognitive changes that can occur in patients. Fatigue and even falls have been reported related to this drug. So that is something that's being explored, probably affecting a subset of the patients. My own personal feeling is that this might be more of an effect on elderly patients as opposed to younger patients.
Okay. Next, application in medicine. In this double-blind phase 3 trial, we randomly assigned in a 2-1 ratio men with non-metastatic castration-resistant prostate cancer and PSA doubling time on 10 months of life. We were conducting androgen deprivation therapy to receive enzalutamide at a dose of 116 mg or placebo once daily. The primary endpoint was metastasis-free survival, defined as the time from randomization-free radiographic progression and as time to death without radiographic progression. Results: Okay, a total 1801 patients median PCA doubling time, 3.7 months, underwent randomization, and as a Juni 88, 117, and total of 219 of 933 patients, 23 patients in the simulated group as metastasis or had died, as compared with 228 of 468 is 48% in placebo groups. The median metastasis-free survival was 36.6 months in the insulin group versus 14.7 months in the placebo group. Hazard ratio for metastasis or death is 0.29 or 95% confidence intervals, or 0.24 to 0 to 2035 p. The time to the first use to subject antineoplastic therapy was launched with enzalutamine treatment with placebo, as has the time to PSA operations. At first intermittent analysis of overall survival, 102 patients, 11% receiving enzalutamide and 62 receiving placebo had died. Adverse events of grade 3 or higher concurrent of 31% of the patients receiving enzalutamide, as compared with 23% of those receiving placebo. Next video.
The PROSPER study was a global randomized controlled trial of enzalutamide in men with non-metastatic CRPC and greater risk for disease progression based on a PSA doubling time less than 10 months. Patients were randomized in a 2-to-1 manner to either enzalutamide or placebo. The primary study endpoint was metastasis-free survival. Compared to placebo, enzalutamide resulted in a 71% reduction in risk of metastasis or death. Enzalutamide was generally well tolerated with relatively few patient discontinuations due to adverse events. Apalutamide and enzalutamide are structurally similar novel anti-androgens. Apalutamide in non-clinical studies has a lower CNS penetration and may have certain safety advantages. It's important to note, though, that there have been no head-to-head studies of apalutamide and enzalutamide. Apalutamide is currently approved for the treatment of non-metastatic CRPC. That approval was based on the results of the SPARTAN study, and the FDA approved apalutamide in that setting on February 14, 2018. The PROSPER study was very similar to the SPARTAN trial, and FDA review of enzalutamide for non-metastatic CRPC is ongoing. The package insert for apalutamide in non-metastatic CRPC includes two important safety considerations. Apalutamide was associated with a higher rate of falls and fractures, and all patients receiving apalutamide should be assessed for their fracture risk and consider drug therapy to prevent fractures in appropriate patients according to national guidelines. Seizures are also listed on the package insert. 0.2%, or 2 patients in 1,000, were observed to have seizures in the apalutamide pivotal trial, and any patient who experiences seizure activity during apalutamide treatment should permanently discontinue the medication. The ARAMIS study is the third study of a potent anti-androgen in non-metastatic CRPC. The ARAMIS study is a global randomized controlled trial of darolutamide in men with non-metastatic CRPC and greater risk for disease progression based on the same PSA doubling time cutoff of less than 10 months. In contrast to PROSPER and SPARTAN, the darolutamide trial does not blind patients or providers to PSA results on study, so it'll be interesting to see what that feature of the trial, how that will impact subject retention on the study. The study completed accrual in February 2018, and results are expected based on event-driven analyses.
Okay, the next video.
For the terrain trial, myself and Axel Heidenreich from Germany, we were the co-PIs for this global trial. It was a large phase 2, 375 patient trial. And it was a head-to-head trial of enzalutamide versus bicalutamide for patients with either asymptomatic or minimally symptomatic M1-CRPC. And the results of the trial very nicely show that progression-free survival at the median was improved by 10 months for the patients on enzalutamide versus bicalutamide, with a hazard ratio of 0.44. We also looked at PSA declinations, quality of life, and it significantly favored the enzalutamide arm. Looking at adverse events, no new signals compared to large phase 3 trials that we already had with enzalutamide, known as the PREVAIL pre-chemotherapy trial and the AFFIRM post-chemotherapy trial. So no new safety signals, but obviously in a head-to-head, which we rarely and frequently seen, clearly besting an earlier generation androgen receptor inhibitor, bicalutamide, both in terms of delaying radiographic progression, as well as its impact on PSA, and a FACT-P score with subscale evaluations.
Okay, conclusion. In conclusion, among men with nonmetastic castration-resistant prostate cancer with a rapidly rising PSA level, enzalutamide treatment led to a clinically meaningful and significant 71% lower risk of metastasis observed than placebo. Adverse events were consistent with the established and safe profile of enzalutamide. Okay, last video.
Apalutamide is another second-generation androgen receptor antagonist, similar to enzalutamide. It too has a chance of seizure. It too brings down the PSA. It too can shrink tumors, and it has not yet been shown to improve survival compared to placebo. Apalutamide has similar side effects to enzalutamide. It should not be used in patients with a history of seizure. It could possibly decrease cognitive function, could possibly increase the risk of falls, and I haven't mentioned it yet, but all these agents can also cause decreased bone density. There is nothing worse than uncontrolled prostate cancer. Every treatment we use to fight it has side effects, but compared to uncontrolled prostate cancer, they're relatively minimal. So then we compare the toxicities of the agents available to us, and drugs like apalutamide are easier for patients to take than chemotherapy and have much less effect on the bone marrow, fatigue, neuropathy. So I believe that the side effects are worth the efficacy that these drugs have. The Spartan study looks at men with non-metastatic prostate cancer who have a PSA doubling time of under 10 months. It randomizes those men in a 2-to-1 fashion to apalutamide versus placebo and follows them forward in time for side effects, toxicities. They collect data on the PSA, but that's not known to the patient or physician. They check imaging studies every 4 months until the patient develops metastases. And the primary endpoint of this trial is metastasis-free survival, with secondary endpoints including time to next treatment and overall survival. The clinical significance of the Spartan study can be very profound because we have quite a few patients in this realm of having non-metastatic castration-resistant prostate cancer, and we don't have many things to offer them. So the clinical impact is that we can use it and delay the time to metastases. So as a physician, my patients and I are very concerned when they develop a tumor on a bone scan or a CAT scan. And if we can possibly delay that, we could delay some untoward effects of the cancer and potentially, maybe by the Z article, prevent death or delay it. I think it'll have a very profound impact on the clinic. The approval of apalutamide will cause these AR antagonists to move forward in the treatment of prostate cancer. It could also move up chemotherapy and some of the other treatments for metastatic cancer. These AR antagonists being used earlier will also make it more difficult to give patients abiraterone because of the cross-resistance between these AR receptor antagonists and abiraterone. I can see us potentially using more chemotherapy.
Okay, thanks for watching.